Hello, our name is The Cartel, and today we will be discussing acute renal failure.
Disclaimer: the cartel has no affiliation with the creation, transportation, or distribution of illicit drugs. Thank you.
The case study reads, a 70-year-old man is chronically taking digoxin for atrial fibrillation. He was brought to the hospital 2 days ago, hypotensive and septic, due to the high-grade bladder outlet obstruction. Despite resuscitation with fluids, pressors, and antibiotics, he is now making only 5 to 10 milliliters of urine per hour. His initial bacterial culture showed Pseudomonas sensitive to gentamicin. How will you handle his digoxin and gentamicin therapy in the face of his acute renal shutdown? What information will you need? On the left, you can see the inside of a normal kidney. The right side shows the nephron, or the functional unit of the kidney. There are approximately 2 million nephrons in each kidney. Nephrons begin in the cortex, the tubules dip down to the medulla, then return to the cortex before draining into the collecting duct. To begin, substances from the blood are filtered into the blood vessels and enter the tubule as a filtrate. These substances can include sodium chloride, potassium, bicarbonate, water, glucose, amino acids, or urea. However, red blood cells and large proteins should never be present. Following filtration, the proximal convoluted tubule works to reabsorb ions, waters, and nutrients, all while removing toxins and adjusting the pH of the filtrate. The filtrate will then enter into the descending loop of Henle, where aquaporins will allow for water to pass from the filtrate into the interstitial fluid. Next, the filtrate enters the ascending loop of Henle, where reabsorption of sodium and chlorine into the interstitial fluid occurs. Following the ascending loop of Henle, the filtrate will enter the distal tubule, where there will be a selective secretion and absorption of the different ions in order to maintain blood pH and electrolyte balance. Finally, the filtrate will enter the collecting duct, where the final reabsorption of solutes and water will occur. Then, it will descend towards the renal pelvis and empty the formed urine into the ureter. The kidney has several roles that ensure the normal functioning of the body. One of these roles is waste excretion. There are many things your body doesn't want inside of it, so the kidney filters out toxins, excess salts, and urea, a nitrogen-based waste created by cell metabolism. Urea is synthesized in the liver and transported through the blood to the kidneys for removal. Water level balancing is another important function of the kidneys. As the kidneys are key in the chemical breakdown of urine, they react to changes in the body's water level throughout the day. As water intake decreases, the kidneys adjust accordingly and leave water in the body instead of helping excrete it. The kidneys also serve as ways to regulate acid within the body. As cells metabolize, they produce acids. Foods we eat can either increase the acid in our body or neutralize it. If the body is to function properly, it needs to keep a healthy balance of these chemicals, which the kidney plays a large role in doing. Blood pressure regulation is another function of the kidney. The kidney needs constant pressure to filter the blood. When it drops too low, the kidney increases the pressure. One way is by producing a blood vessel constricting protein, angiotensin, that also signals the body to retain sodium and water. Both the constriction and retention help restore normal blood pressure. Another important function of the kidney involves the regulation of red blood cells. When the kidneys don't get enough oxygen, they send out a distress call in the form of erythropoietin, a hormone that stimulates the bone marrow to produce more oxygen-carrying red blood cells. The aforementioned functions are a few of the many things the kidneys do to help the body function properly. Other notable kidney functions include the regulation of total body water, the regulation of electrolytes, calcium and phosphorus, the hydroxylation of vitamin D, and the metabolism and removal of drugs. Acute renal failure is a short-term, 2 to 3 day halt of kidney function. Causes of renal failure include a lack of blood flow to the kidneys, direct injury to the kidneys, specifically damage to the nephron, halting filtration, and blockage of the ureters leading to backflow of urine and keeping the filtrate from moving through the nephron. The main symptoms of acute renal failure are low urine output, pedal edema, and chest pains. If the kidney is failing, there is an accumulation of systemic water volume. This leads to water being deposited in the extremities and the pulmonary circuit, where it causes chest pain and edema of the extremities. There are also risk factors for acute renal failure, such as an age of 65 plus, a pre-existing kidney disease or problem, high blood pressure, a pre-existing chronic disease like heart disease, liver disease, or diabetes, and finally, a pre-existing artery disease that causes a shortage of blood flow to the extremities.
In reference to the case study, the 70-year-old man is taking digoxin for atrial fibrillation. Digoxin inhibits the ATPase on the cardiac myocyte to decrease the calcium release from the myocyte. This will allow for higher intracellular calcium ion concentration in cardiac myocytes, which will cause a stronger contraction. Thus, digoxin is commonly used to treat congestive heart failure and supraventricular arrhythmias. However, it can also be used to control the ventricular rate in the treatment of chronic atrial fibrillation. Since the majority of digoxin is excreted renally, patients with renal failure will not be able to eliminate the digoxin. In normal functioning kidneys, the excretion rate should be 36 to 48 hours. However, in failing kidneys, the excretion can last anywhere from 3.5 to 5 days. This is the main pharmacokinetic issue with patients who have kidney and liver issues and are taking digoxin. The following illustrates the mechanism of action for digoxin. Overall, the increased intracellular calcium concentration leads to an increase in cardiac contraction. First, digoxin inhibits the sodium-potassium ATPase membrane pump, which is a primary active transporter, resulting in a decrease in extracellular sodium. Therefore, there will be a diminishment of the sodium gradient, which would power the NCX sodium-calcium exchanger, a secondary active transporter. Thus, the sodium-calcium exchanger will not function, so there will be a buildup of intracellular sodium and calcium. This calcium allows for stronger cardiac contractility via binding to troponin C, activating the contractile proteins. This slide outlines the different effects that digoxin can have at different levels. At a subtherapeutic level, it will not have a high enough concentration to make a change. At a therapeutic level, it will allow for stronger, slower heartbeats because the calcium builds up in the myocyte, leading to stronger contractions. It also decreases the excretion rate of the calcium from the cell, which means that it will be unable to relax as soon, extending the time it takes to stop the contraction, so it will contract again. At toxic levels, you can have tachycardia, where the contractions occur more rapidly than they should, or heart block because the heart is unable to propagate action potentials in a hyperkalemic environment. In the case study, gentamicin is paired with digoxin drug therapy. Gentamicin is in the drug class aminoglycosides, and it is used to treat bacterial infections. The bacteria that the patient has is sensitive to gentamicin. This drug binds to the 30S subunit of the ribosome, overall preventing protein synthesis. It is shown to cause nephrotoxicity, thus it should be administered intermittently. The main pharmacokinetic issue is the combination of nephrotoxicity and renal excretion, leading to a drop in excretion as it is toxic to the organ responsible for its elimination. The following illustrates the mechanism of action for gentamicin. Aminoglycosides like gentamicin irreversibly bind to the specific 30S subunit of bacterial ribosomes. This interferes with the decoding site in the vicinity of nucleotide. This region interacts with the wobble base of the anticodon of tRNA, which leads to the interference with the initiation complex, misreading of the mRNA, so incorrect amino acids are inserted into the polypeptide. At subtherapeutic levels, there is no noticeable change to the level of bacteria. At a therapeutic level, the bacteria are killed to treat the infection. At toxic levels, the same mechanism that allows gentamicin to kill bacteria can also kill cells of proximal convoluted tubules. This causes nephrotoxicity and also acute kidney failures. The acute renal failure caused by gentamicin leads to a decrease in renal excretion. This decreases the elimination portion of the pharmacokinetics. Thus, the concentrations of the drugs increase despite being the same doses, increasing the half-lives of the drugs greatly. This brings them much closer to their toxic doses, which increases the change of toxicity of both drugs. The toxicity of gentamicin feeding back into the lack of excretion. How will you handle his digoxin and gentamicin therapy in the face of his acute renal failure? Well, we need to lower the digoxin dose because it is mostly released into the urine, which is no longer being made. Oof. And it is being increased by the gentamicin already. This puts them into a range that has a high likelihood of entering the toxic range. Also, the dose of gentamicin should be lowered as treatment for his secondary acute renal failure. This is based on the half-lives of the drugs in patients diagnosed with renal failure. If this course of action is not taken, the digoxin will build up in the serum, pushing the patient to toxic range. This will increase the likelihood of gaining toxic effects from digoxin. These toxic effects include arrhythmia, specifically tachycardia, which is caused by hyperkalemia and issues clearing calcium, as well as heart block caused by hyperkalemia and stopping action potential transduction. Here are our references.